All right, welcome to the prostate cancer part 9, stage and grade. Gleason score. The Gleason score is determined by architectural patterns of prostate gland. Cellular characteristics such as mitosis are not considered in this score. So this score is known as Gleason score. Is determined by architectural patterns of the prostate gland. The two most around abundant patterns are assigned a number from 1 to 5. These two patterns numbers are added to obtain the Gleason score. The Gleason score is reported as the most abundant patterns plus the second most abundant patterns followed by the sum example 4 plus 3, 7 out of 10. The higher Gleason score, the higher the Gleason score patterns, and the higher the Gleason score, the worse prognosis. Tertiary patterns might be reported when there is a smaller amount of the Gleason score pattern 4 or 5 because their presence, even if it is scant, that's pretended a worse prognosis. This is the Gleason score pattern from 1 to 5. And this is the two confined to well circumscribed nodules. This stromal present between each glands and the variability in the gland size and morphology. So Gleason 1, the tumor is usually confined to well circumscribed nodule and stromal present between each gland and also no variability in the gland size and morphology, large uniform gland. This is the Gleason 1. The Gleason 2, the tumor is also confined to well circumscribed nodules and the stromal present between each glands with a minimal variability in the gland size and morphology. Gleason 3, thus the tumor confined not to well circumscribed nodule, it is irregular nodules, and it is yes, the stromal present between each gland, and here we have moderate variability in the gland size and morphology. Gleason 4, no, the tumor is not confined to the stroma nodules, so we have irregular nodules and the nodules and also no stromal present between each gland, so it's fused gland. Okay, and also the variability is fused gland and it is back-to-back glands or cribriform gland. This is Gleason 4. Gleason 5, here this is the tumor is not confined to the nodule, and also the tumor cell does not form glands, solitary tumor cells or cell packed together in the sheath or net. This is the Gleason 5. So cribriform pattern, that means the tumor appear to have small open space or hole when viewed under the microscope. Group grade. The International Society of the Urological Pathology, that ISUP, developed a new reporting system for prostate cancer grading, which was subsequently adapted by the World Health Organization, the WHO. It's known as International Society of Urological Pathology. It utilizes the Gleason system to determine a grade group. So this grade group is using the Gleason to utilize the Gleason system to determine the grade group. The higher the grade group is, the worse the prognosis. It's known as International Society of Urological Pathology. So this is the International Society of Urological Pathology WHO grading group 1, 2, 3, 4, 5, and this is the Gleason score. So the 1 is less than or equal 6, 2 is 7, and 3 is 7, 4 is 8, and 5 it is 9 to 10 Gleason score. So this is the ICUB WHO grading system. The Gleason buttons requirement. Gleason 1 that's grade group 1 that's less than or equal 6, no buttons 4 or 5. Gleason 2 or grade group WHO grade group 2 or ISUB is up, or ISUB grade group 2 it's equal to the Gleason score 7, that's 3 plus 4. Gleason the grade group WHO grade group 3, that is Gleason score 7, and Gleason pattern required it's 4 plus 3. Gleason grade group WHO 4, it is equal Gleason score 4, and any patterns of Gleason score. Grade 5 ISUB grade 5 or WHO grade 5, that's Gleason score 9 to 10 on any patterns of Gleason patterns required. So the most important two grade in WHO or ISUB, that the grade 2 and 3. 2 that's it's 7 and actually 3 plus 4. 3 that is 7 and also 4 plus 3 in the Gleason pattern. So PSA to stage prostate cancer. Higher pre-treatment PSA increase the risk for capsular penetration, seminal vesicle invasions, lymph node metastasis, and the distal metastasis. This is higher pre-treatment. Higher pre-treatment increase risk of capsular penetration, seminal vesicle invasion, lymph nodes metastasis, and distal metastasis. All this come with pre-treatment high PSA. PSA is a part of criteria used to determine the risk category. So it is part of the criteria to determine the risk of the category. Imaging to stage the prostate cancer. The two most common sites of metastasis are bone and pelvic lymph nodes. This is the two most common. Therefore, imaging for metastasis are focusing on this site. The sites of bone and lymph nodes is very important. So distal metastasis, bone scan is initial imaging exam to check the distal metastasis. Regional lymph nodes, metastasis, regional lymph nodes are located in the true pelvis below the bifurcation of the common iliac arteries, pelvic, hypogastric, obturator, iliac, and sacral node. So this is the regional lymph nodes. This risk of cancer in the regional nodes can be assessed using normograms such as Partin tables. So use normogram to assess the regional lymph nodes. However, any stage is determined by pelvic imaging, CT or MRI, or by pelvic node sampling. Men with symptoms suggestive of metastatic disease. All men with symptoms suggestive of metastatic disease should undergo imaging for metastasis. Men without symptom of metastatic disease, imaging the local extent of the cancer in men who are candidate for curative therapy, prostate multiparametric MRI may be useful to help identify extraprostatic extension. Example to assess for involvement of the neurovascular bundles when nerve sparing is being considered. Trust is not accurate for a local staging. Imaging for metastasis. The recommended initial imaging is based on risk level. This table shows a recommendation of initial imaging to assess metastasis in men without cancer-related symptoms that's adapted from the NCCN, AUA, and EAU. This is the initial imaging. That's the risk group, very low risk, technetium, no need to do technetium bone scan 99. Low risk, no need to do technetium 99. This is in this group. Favorable intermediate risk, it's optional. Optional in main bone scan meet by optional by AUA, but not recommended by NCCN or EAU. But the AUA mentioned that you can do imaging by technetium 99M bone scan for favorable intermediate risk. Unfavorable intermediate risk, both NCCN and AUA and even EAU can recommend doing the technetium bone scan 99M. High risk, yes, it's obviously like unfavorable intermediate risk. We can do technetium bone scan. Abdominal cross-sectional imaging such as CT or MRI. In very low risk or low risk, we not um, required to do this, or it's not important to do CT or MRI in this group. But in favorable intermediate risk, recommended if normogram indicate more than 10% of regional lymph nodes is, so if we have these lymph nodes, we can, in this means cross-sectional imaging was made by AUA. AUA, it's two mentioned can do, but not recommended by EAU. The NCCN, CT or MRI, if normogram is more than 10% as we mentioned. Okay, so AUA recommend to do abdominopelvic cross-sectional if favorable, intermediate risk, but the EUA, it is not recommend this. NCCN is as well if the recommended if normogram indicate more than 10% of the regional lymph node metastasis. Unfavorable risk, intermediate risk, or high risk, yes, we can do technetium and we can do CT or MRI in both groups, intermediate unfavorable risk or high risk. Okay, so multiparametric MRI may be able to detect nodal metastasis better than CT. The NCCN prefer multiparametric over CT assessment of the pelvic lymph node, while AUA and EAU had no preference of one over the other. MRI, CT may be referred with and or without intravenous contrast. So remember, the NCCN prefer multiparametric over the CT compared with AUA or an EAU guideline. Consider obtaining bone scan in men with elevated alkaline phosphatase. A higher BSA and higher gleason score increase the probability of having positive bone scan. If bone scan is inclusive, then additional imaging of the suspected area can be obtained using plain X-ray, CT scan, MRI, PET scan, CT scan, or a PET MRI PET scan should be done with one of the following agents: that the NAF18 or prostate BCMA, prostate specific membranous antigen, or polycyclophin. This is the three agent that it's preferred to do it with PET scan. PET scan should be done with one of these agents. If this additional imaging is still inclusive, then bone biopsy might be necessary. This is the total BSA by nanogram per ml, and this is probability of positive bone scan. If the total BSA is less than 10, the total less than 10, the probability of having bone mets or positive bone scan 2.3%. 10 to 20% that the probability of having bone positive bone mets or positive bone scan 5.3%. If 20 to 50, that's the total BSA, so it is 16%. If the total more than 50, so probability of positive bone scan is more than 35%. That's the biopsy gleason score. That the initial diagnosis less than or equal 7, Probability of having positive bone scan 5.5%, more than or equal 8. The probability of having a positive bone scan or bone involvement is 28%. Using BIT for initial metastatic evaluation is not recommended. BIT might be useful when the initial metastatic evaluation is inclusive or negative despite a high risk for metastasis. Also, PET scan can detect more small volume metastasis. It is unclear if there is a benefit to detecting this metastasis at the early time. There is minimal data on whether the basing treatment decision on the PET improvement a patient outcome. Also, these tests have a significant false positive rate. Thus, the NCCN recommended biopsy of a PET scan positive lesion when feasible. This is the end of the session.